Thank you, Andy. So it's a pleasure to welcome Webb, who's just joined us of COVID-19 patients and will tell us more. Thank you, Will.
So hello, thank you for the opportunity to present. As Bill said, my name is Webb, recently joined the liver unit here in Cambridge, going to speak on COVID-19 and the liver. I'll start just by saying that a lot of what I'll talk about is from this COVID Het registry. Some of you may be familiar with it, and EASL were kind enough to give us some financial support. What I'm going to go through briefly is some of the direct effects on the liver, some outcomes in chronic liver disease, as in how do patients with chronic liver disease do when infected with SARS-CoV-2, then the same in liver transplant patients, and then some discussion, and this is a little more theoretical, but around the indirect effects of the pandemic on liver patients, and mention some things that I think it's important that we should know that we do not currently know. Just to set the scene, I'm not going to speak particularly about the classic clinical syndrome of COVID-19 with this sort of cytokine storm and rich IL-6, IL-8, TNF-alpha release associated with delayed lung damage after the onset of symptoms, but did just want to show these graphs and going through just to show really that there's an ongoing linear and perhaps even exponential increase in numbers of cases worldwide. And actually worldwide, we've actually had a fairly linear death rate now for over 6 months. So everything is continuing. And of course, we have just re-entered some form of lockdown here in the UK. But on the back of this, and this is the pinch of salt to take with some of what I'm going to present, is this is simply the number of cases and the number of deaths divided into each other, giving the case fatality rate. And that, of course, as testing has improved and widened, has decreased, and to some extent, perhaps as treatment has improved. So data taken from the peak here will have higher mortality rates, or be likely to, from later work. And if one reads the literature, the true case fatality rate is estimated down here at 0.5% or so. In terms of direct effects on the liver, I'm just going to talk briefly about the results of one large cohort study, but there are many, many units that have put together cohorts of liver chemistry in patients with COVID-19. So this being, I think, one of the largest, and from the US, from a group of hospitals. And they defined liver injury based on ALT elevation, so a simple definition, and identified mild injury, so what they define as between 1- and 2-fold upper limit of normal in 45%, moderate in 20%, so that's between 2- and 5-fold upper limit of normal, and severe in 6%, that's over 5 times upper limit of normal. So a relative minority with an ALT over 5 times the upper limit of normal. But importantly, these were all correlated strongly with poor outcome from respiratory cause, but with the caveat that median INR and bilirubin remained normal in all groups, and essentially no patients had very marked elevations in bilirubin or INR. And I haven't put the precise details here, but there's a very strong correlation in all with CRP, calcitonin, interleukin-6 as the most strongly elevated early cytokine in COVID-19, and ferritin. And really, I think this is consistent with the observation that much of what's described as liver injury here is seen as part of the systemic inflammatory response rather than a primary effect. And then when considering whether there's really is a direct effect of SARS-CoV-2 on the liver, I think the jury is still out in total, but in my mind, there are some points for significant effect and perhaps a weight of points against there being a really significant clinical effect. So RNA is present in autopsy studies of COVID-19 patients, and liver chemistry disturbances are frequent, as I've just described. But actually, if one looks through a few autopsy series now coming into the liver, there are no consistent hepatic changes, and more what one's seeing are those of a shock liver or consistent with cytokine release, there's this observation that the key receptor that's used by SARS-CoV-2 for entry into cells is not actually expressed on hepatocytes at all. It's expressed at a low level on hepatic sinusoidal endothelium, although it is expressed rather more on cholangiocytes. But balancing that, the injury that's seen is primarily hepatocellular and not biliary. Significant disturbance of synthetic function is rare. And actually, if one looks at the literature for disturbances in influenza, it's essentially the same. So we're seeing the same thing. There's others have described what's being seen as similar to the pattern seen in cytokine storm and cytokine release syndrome seen in hematology. So in my mind, it's the liver, at least in terms of direct injury, is probably more of a bystander. However, how our patients cope with the systemic syndrome, I think, is very interesting and very important. And in terms of chronic liver disease, wanted to start mentioning this work. So as people will remember, much of the European epidemic started in northern Italy, and this study is from Lombardy up here, and is a multi-hospital cohort of a combination of 50 patients with cirrhosis and COVID-19. And to summarize, the key thing here is they found an overall mortality in cirrhotic patients with COVID-19 of 34%, so really quite significant. And importantly, although these are patients with advanced liver disease, some of them, the vast majority were dying from lung respiratory issues rather than liver-related causes. And they recorded a strong association with liver disease severity. I've just pulled out their odds ratio with 1 point of MELD and risk of death here being significant. But they made this observation within the paper that there was no difference from matched patients with cirrhosis and bacterial respiratory infection, perhaps suggesting it's the ability to handle the insult. And here on the right, Kaplan-Meier plots divided with the solid line being a MELD of 15 plus, with a 30-day mortality of 70%, 70%, so really very significant, and still an appreciable mortality in cirrhotic patients of 22% in those with a MELD of under 15. And then really building on the work from the Italian group and collating work from internationally, I was involved with establishing the COVID Heb registry, and we've partnered and ultimately synchronized everything with a separate registry based in North Carolina, Secure Cirrhosis. And what this is, based from Oxford over here in the UK, an open online reporting registry with a unified report form to invite clinicians to report details of their cases. I shan't go into too much detail, but essentially we took everything as was reported, only cleaned to removing complete entries and duplicates. In terms of what I'll present in a moment, consecutive with collecting this data, at least until the point of the publications I'll present now, we simultaneously collected matching data on every patient who was diagnosed with SARS-CoV-2 in the 4 Oxford University hospitals. I should note at the outset that, of course, any registry study has potential issues with reporting bias, be that people reporting rarer presentations or more severe outcomes, all possible. But we did end up with quite a number of submissions from a number of centres, so over 30 countries and over 100 centres ultimately included in the analyses. And in terms of our chronic liver disease publications in Journal of Hepatology a few weeks ago, this is the plot of key outcomes. So just moving from left to right, and these bars are coloured, so blue being CLD, so chronic liver disease without cirrhosis, that's 350 odd, and then around 380 patients with cirrhosis, so red being child baseline prior to diagnosis of COVID-19, Child-Pugh A, green Child-Pugh B, C Child-Pugh C. And you'll see that rates of hospitalization were similar across those groups within the registry, but outcomes are very significantly different. So in terms of ICU requirement, as adjudged by the submitting physician, there's a significant gradient with severity of baseline liver disease. And then ICU admission, the same. The reason we separated these is a proportion of patients a decision was taken that ICU was required but not suitable based on their background liver disease. And you can see that reduces each of these bars slightly. And much more so for the advanced liver disease than for those with chronic liver disease only. Renal replacement therapy was significantly associated with baseline liver disease, less rates of invasive ventilation, although I think this possibly reflects some of this not taking people to intensive care. And I think most importantly, this very strong gradient with death. So we've got about 50% mortality in those with Child-Pugh cirrhosis, and a stepwise down here. And these pictures are just to emphasize 2 points really taken from our graphical abstract. So of those with cirrhosis, decompensation events, so we defined this as new or worse hepatic encephalopathy, new or worse ascites, variceal bleeding or spontaneous bacterial peritonitis were frequent and not necessarily associated with respiratory symptoms. So 46% of those with cirrhosis just experienced one or more of those. And then similar to the Italians' work that I've just mentioned, the majority of these patients are dying from respiratory failure, not liver causes. This is a large table of our univariable and multivariable analyses in terms of association with death, but I'll just highlight a few points if I may. So first, as in everything published about COVID, age strongly correlates with outcome. This is the multivariable analysis in the rightmost column. Second, we had this modest but consistent signal that alcohol as an etiology for chronic liver disease was independently associated with an additional risk from poor outcome from coronavirus. But then just how dominant, given this list of cofactors being accounted for here, is chronic liver disease in the outcome of these patients. So we have odds ratios for cirrhosis at Child-Pugh A of 2, 4 for Child-Pugh B, and 9 for Child-Pugh C. So really significant and strong effect. This plot is of fatality by age group, and the difference you'll see is that mirroring what one sees if one looks at a study of the general population, this strong correlation with age in chronic liver disease, but in cirrhosis, significant mortality in all age groups presenting with COVID-19 with cirrhosis, with the red bars going out quite far to the right. And further, this these adverse outcomes are persistent depending on when one looks at the data. So the data I presented earlier was all comers, but if one looks once hospitalized, this is mortality. You'll see a strong gradient with severity of liver disease. This is color-coded for ease of interpretation. Then again, once admitted to ITU, and then again, once receiving ventilation with 90% mortality for those ventilated with Child-Pugh C. We had 20 cases in that group. So really very significant and relevant, of course, to those of us looking after such patients and prognosticating and making decisions about going to intensive care. And then I mentioned in presentation, we also took information from Oxford, and this is a propensity score matched analysis, one-to-one between the liver disease cohort collected online and the Oxford cohort of people without chronic liver disease, here labeled non-chronic liver disease, matched on age, interactions with age, sex, presence or absence of COPD, diabetes mellitus, and any form of heart disease. And you'll see really the same findings. So this is different, absolute difference in mortality rate. So in this analysis, the Child-Pugh A was not significant, but B and C very certainly were, with around a 30% absolute mortality difference, i.e. 10% in one group to 40% in the other. A criticism we received in review was that the cohort was heterogeneous, so we restricted our analysis to UK submissions and actually seen the same pattern on this. So this is UK submissions to the registry from across the UK matched against Oxford. And some of you listening may have been involved in submitting cases. This is a map of where they came from. Thank you very much if you were, very grateful. So on this section, I think one can summarize that there's a strong correlation with poor outcome in COVID-19 and severity of baseline liver disease. Decompensation is frequent in a proportion without respiratory symptoms. I haven't shown that data, but that certainly was the case. Ultimate cause of death was predominantly respiratory, possible additional contribution from alcohol etiology. And I just note here that the very recent UK guidelines suggest shielding in decompensated cirrhosis and those awaiting liver transplantation. Simultaneously, we collected data for our liver transplant, or for liver transplant patients. Same mechanism, but just divided the two analyses into two separate publications ultimately. But I want to start with some others' work. So there are two summaries of two other publications here. The top bar here is a Spanish registry, so across Spain. And what this is showing is in the thick black line rising here, the cumulative incidence of diagnoses of COVID-19 amongst their liver transplant patients, and in the yellow bars, the general population, the point being that one mirrors the other almost exactly. The same thing for the UK is shown here, although the caveat here is that NHSBT have published for all solid organ transplant recipients. So here in the blue line for solid organ transplant recipients and the black line for overall cases in England. So there is perhaps a certain amount of lead time here, but not enormous, and coming together with time suggesting at least in the wild no hugely greater susceptibility. I note that the Spanish mortality overall was 18% amongst their liver transplant patients, the UK 20%. And I shan't go into the details, but the crux of the Spanish paper was after analysis and correction for weight of comorbidity, no difference between the Spanish transplant and non-transplant cohorts in developing what they termed severe COVID-19. So that was ITU admission, death, or requirement for mechanical ventilation. In the Spanish study, age and comorbidity associated with severe COVID-19, as in everything with COVID-19. And then these data are now from the COVID HEP and secure cirrhosis registries. So similar to that I showed earlier for chronic liver disease, but colored differently. So here the blue, this is the Oxford comparison cohort, the same cohort. The size is slightly different because we filtered the patients slightly differently. No difference in requirement for intensive care. You'll see there's a big jump here. There are a number of frail elderly patients who were thought not appropriate for intensive care in Oxford. So there was a reduced rate of ITU admission versus non-transplant patients, and similarly invasive ventilation. But overall, in an unadjusted comparison, fewer deaths amongst liver transplant patients as compared to the general population. If you cast your mind back to the chronic liver disease tree plot I've called this, so case fatality rate broken up by age band, you'll see that actually there's a relatively similar pattern for the liver transplant patients as for those in patients without transplantation, non-liver transplant patients, the Oxford control cohort on the left. And again, a busy table, but this is the univariable but multivariable analyses for a number of covariables within our transplant cohort, which was 151 patients with liver transplant, and showing that age, a non-liver cancer diagnosis, or renal function were all associated with adverse outcome, but not certain, say, prednisolone use, calcineurin inhibitor use, antimetabolite use, so that's mycophenolate or azathioprine, didn't have sufficient data for sirolimus, but those sort of associated comorbidities rather than the liver or the immunosuppression itself within that analysis appearing most important. And then similarly to the propensity score matched plot I showed you earlier for the chronic liver disease patients, this is difference, absolute difference in risk of death in those with liver transplantation compared to those without, this dashed line being no effect. And we built several propensity score matched analyses on combinations of age, sex, obesity, ethnicity, hypertension, diabetes, and renal function. And none of these showed a significant difference in outcome, as in risk of death once diagnosed between transplant and non-transplant patients. And then more recently, this is a single figure from a paper coordinated by Julia Hipsley-Cox. It's also from Oxford. This is Q COVID, so based on the Q Research aggregate GP records database. And this is following 8 million patients, but they split the analyses up. So this is for 3 million UK women, but the results are similar for the men, sort of followed prospectively over time in this database. And the things I wanted to draw attention to were, one, with renal dysfunction, they show increased association. This is association with mortality to the right of the figure, very significant in those transplanted, noting a small typo there, but coronary kidney disease stage 5 with transplant. But actually, if they take out the kidney transplant patients and look at solid organ transplant patients, most of whom were liver transplant patients, there is no difference, no significant difference from those without contributed by liver transplantation. Finally, this is a plot of our own data and the Spanish cohort I showed you at the start, coloured by red for death and blue for survived a diagnosis of coronavirus, with age and the Charlson Comorbidity Index, which is an aggregate of a number of different comorbidities accruing points, but with age taken out so it can be plotted on the other axis. And you'll see, I hope, that actually it's those who are comorbid to the right or elderly to the top of these plots that are disproportionately dying, and these with stars are those with comorbidities not captured by the Charlson Comorbidity Index. And this really mirrors our comparison cohort on the right. So this is patients without liver transplant. My point being that I think comorbidity is most important. Transplantation itself is not. Another point of interest that came out here is that gastrointestinal symptoms associated with COVID-19 are present in a minority of those without transplants, perhaps 10 to 20%. But in a number of cohorts, so a US cohort from New York, and a second one from New York, but this is mixed solid organ recipients, the Spanish cohort that I presented earlier, and our own, so 31, 42, 34, and 30% had gastrointestinal symptoms, primarily diarrhea. And we matched those one-to-one with the Oxford cohort, and they're about 3 times as likely to have GI symptoms, with a reasonable proportion only having GI symptoms of the transplant patients, potentially important. So in summary of that, I don't think there's any clear additional risk imparted by liver transplantation based on the evidence so far. This being chronic patients who've been established for some time, age and comorbidity are important, gastrointestinal symptoms may be prominent. There are, however, few data on optimal immunosuppression regimens and on outcomes early after liver transplant. However, the new UK guidelines still recommend shielding for all of those with liver transplant. I just wanted to mention briefly indirect effects. This is more conjecture, but if one looks into reviews of coronavirus's effect on almost any disease, one often sees diagrams like this. So direct effects, as in of infection on the patients, the disruption to medical services as a second wave, a second peak. Here I've mentioned diagnostics, prevention of complications of cirrhosis, HCC therapies, and then societal and systemic effects as a third peak in terms of alcohol consumption, dietary changes, drug use, sedentary lifestyles, etc. Now, we don't have much to inform our understanding of this, but I just have a few figures that I think are useful to show. This is data from operational information for commissioning in NHS England, just showing the effect of the coronavirus pandemic in the UK and the lockdown indirectly on the number of non-obstetric ultrasounds. Clearly, the majority won't be for liver disease, but will be amongst those. It's the best data I could find, and on gastroscopies. So huge reductions in both. Further, if we look at transplant activity, on the left is total solid organ transplant activity, the red line plotting the number of transplants, the grey and black at the bottom, the number of coronavirus cases in the UK. You'll see a really very significant reduction here. And we're now here, perhaps seeing a reduction. The right panel shows just liver transplants. And again, where this trend will follow, we don't know, but there certainly was a significant effect back here. This is from the US, Veterans Affairs, hospitalizations in patients with cirrhosis. So these are almost all military veterans, almost all men, but it's a nicely centralized data set. The dashed line here being the, as it says, first publicized US COVID-19 death. And these are admissions of patients with cirrhosis to hospital. And you'll see that they have really tailed off. What I haven't put here is that the MELD score of those who were admitted went the other way. So perhaps sicker fewer but sicker admissions, and perhaps people putting off or trying to put off their admission. This is just to make the point that I wonder if we're having an aggregate effect on immunosuppression prescribing. This is from Ben Goldacre's open prescribing site, and looking at the 5-year mean prednisolone prescription in the dashed line behind this. And recently, nationally, we're prescribing rather less prednisolone. Whether this will have indirect effects on our autoimmune patients, I do not know. There is, of course, huge financial damage. FTSE 100 share index has dipped and is starting to dip again with the second wave, which will feed into many of the behaviours that drive the liver diseases we see every day. And this is alcohol consumption. This is via Public Health England, and they've divided it into these sort of social group banding. So A, B, skilled professional, C1, unskilled professional, and then the sort of manual categorizations that they've used. And this is alcohol consumption over time in the coloured bands. This is Christmas, as you might imagine. It's a big peak here, things die down, and then we have a big uptick with lockdown in alcohol consumption in various groups, especially actually the professional groups. This is diagnoses amongst GPs, an aggregate group from Salford. This is type 2 diabetes. I couldn't find anything on liver disease, but they've really fallen off. One could imagine the same happening for ours. I think that's potentially very important, reduced case finding. And then just coming to the end, I wanted to highlight some of the things that I think it's important that we do know that we don't currently know. So channeling Donald Rumsfeld, known unknowns. I think amongst the cirrhosis patients, why are outcomes worse? In publications have talked about disproportionate release of cytokines associated with the innate response in cirrhosis patients, this immune dysregulation. It's unclear whether the cytokine response is exaggerated in our patients. We need to know whether there'll, in both cirrhosis and the liver transplant cases, whether there'll be an adequate adaptive immune response, because of course most of the people we're seeing now cannot have had an adaptive immune response because they will not have encountered the virus before, but will they become immune and stay immune after an encounter or after an immunization? Very important to both groups. We don't know if thrombotic complications are a particular issue. Sadly, we missed that data in my own registry. We don't really know if the chronic liver disease patients are more susceptible to getting infection in the first place. And with regard to liver transplantation, the jury is out on any particular immunosuppression regimen. And there are few reports of those who are immunosuppressed having prolonged viral shedding. So positive swabs ongoing for a prolonged period. And also here really should be the role and the effect of coronavirus very early after transplantation. It's an understudied group. So in summary, patients with advanced cirrhosis do badly with COVID-19 with great excess mortality. COVID-19 is associated with decompensation, but patients still predominantly die from respiratory syndromes. Liver transplantation itself does not appear majorly associated with mortality. Comorbidity appears more important. There are, I think, the potential for many significant indirect effects of the pandemic on hepatology, but numerous questions remain. Thank you very much to the team back in Oxford, Tom, Ellie, Jonathan, James, Carolyn, team in UNC, Andrew and Sid, and all the organisations that have supported us, including our liver for the health of autoimmune work and contribution. Thanks, Bill. I'm pleased to take any questions, which I think appear as text, do they somehow?
Yep, thanks very much, Will. That's great. We're just going to eat into the lunch break a little bit because I think there are a few questions here, which I'm sure people will find valuable. So one question is about shielding, whether compensated cirrhosis should shield.
So I think on the current guidelines, no, they define decompensated cirrhosis. They additionally include synthetic dysfunction, which they don't further define. So that there's some leeway there. I think our data would suggest that there's a relatively modest increased risk to those with Child-Pugh A cirrhosis. However, my own feeling is that the Child-Pugh A cirrhosis are at greater risk than the liver transplant patients once one accounts for comorbidity. So I think they'd be wise to at least take some precaution.
Thank you. I think you showed that alcohol was a factor, but NASH isn't necessarily a factor. Is that correct?
In our work, yes. So alcohol, of course, with NASH, we're correcting for diabetes and hypertension and other things that might be associated with NASH. So that might dilute that effect within that analysis. But yes, alcohol independently a factor.
Okay. Another question here is, what should we advise patients on immunosuppression, for example, autoimmune hepatitis?
So I think we should do what we were doing before, and that's what EASL have recommended and ARSLT have recommended, i.e. carry on as previously, take some precaution to avoid infection.
Okay, we'll just finish off with a few more questions. So what are we doing to disseminate information to the patients, to the transplant patients? I presume that's going out through the patient associations.
So we've been involved with British Liver Trust. They were discussing this. I mean, I think actually we were talking with NHSBT as well, but they've got something planned, but we, as in those of us involved with this registry, aren't directly involved.
Question here about admission to intensive care. We need to be careful whether we're too pessimistic about high Child-Pugh patients. Now we've got better management, could the outcomes be improved?
Well, yes, quite possibly. And one of the things I didn't show is that the likelihood of receiving specific targeted therapy for COVID-19 also went down with advanced liver disease. So I think people were staying away from drug therapy as well as intensive care disease. Another thing that we mean to analyse and present, but haven't quite got ready yet, is that there was significant variation from country to country, given, at least on paper, someone with the same baseline liver disease as to how likely they were to receive intensive care support, which was quite an interesting thing to see come into the registry.
Do you think there's going to be any data emerging about time out from transplant and risk? Is there potentially a case for the very early patients having an increased risk with higher levels of immunosuppression?
Yeah, I think there is, and we had very few who were within a year of their transplant. So I think that's an understudied group. Whether data will come, we've only had about another 30 odd submissions with liver transplants since wrote that paper. So I don't know how much extra we're going to be able to contribute, but it's a risk group, but they're also a very heterogeneous group as well, so it's quite hard to study.
But couldn't that mean they do better early after transplant if you don't have many of them on the registry?
It could do. It could be that they're also not getting it that much, so there aren't enough of them around because they're staying away from it sufficiently. I'm not sure.
In terms of, we've recently seen what we think is COVID hepatitis in a transplant recipient. Has that been reported as a histological entity?
There are a few reports that talk about it, but I think, at least by weight of publication, people think that it's primarily secondary effects. It'll be interesting with our COVID hepatitis. There are plans afoot to stain that individual person's explant liver specifically for the virus. So I think that's going to happen.
Okay. I think in the interest of time, if there are, as I say, if there are further questions which you really want to put to Gwyl, then he's available through Haddenbrook's email or a different
absolutely.
email. Yep.
Sorry, I should put that on there, but yes, absolutely.
Well, thank you very much, Gwyl. That's a fantastic talk to round off the morning session. We'll try and return for a prompt start at 1:15, please. Enjoy your lunch. Thank you.
Thanks.